And so to lead off today, I can think of no better introduction than our former fellow, Dr. Hamshi here is from Sloan. He's part of the myeloma group, which is doing extremely exciting work. And so please welcome Dr. Hamza to discuss this with us.
Very warm morning, everyone. I'm Hamza Hashmi from Memorial Sloan, and in my clinical and research practice, I focus on plasma cell disorders, where I dwell into the 50 shades of myeloma. And when I sent out the presentation, I received an email stating that there may be a typo in the title. And now I have 45 minutes to convince everyone in this audience that when it comes to cellular therapy for myeloma, there's only rise and rise and no rise and fall. So here are my disclosures. Some of the themes and objectives for the presentation today are showing you some of the real world evidence behind the efficacy of CAR-T for myeloma, some of the unmet needs for CAR-T in myeloma, some of the unique toxicities we'll talk about. We'll also show you how we choose and sequence bispecifics and CAR-T for myeloma, and then what are some of the future directions with myeloma. I have a principle that when I give these presentations, I don't like to drown my audience in number, data, stats, and figures. The slides are there, the presentation is with you. You can look at it later. What I will be doing here today is giving you highlights, summaries, take-home messages, show you the controversy, show where the consensus exists, share some of the pearls of wisdom from the grandma's recipe book that I have accumulated over time. And then all along the way, I'll show you how myeloma doctors who like to use memes are very cool. So let's walk through the corridors of history with multiple myeloma. The very first time we stumbled upon a case with myeloma was actually 200 years ago, when in 1845, a young female presented with debilitating hip pain, eventually succumbed to this unknown malady, only found to have a giant red tumor in her pelvis. At that time, we were trying to treat this unknown malady with orange peel. 100 years later, we were not doing anything better, where we were actually doing the first randomized controlled trial for myeloma, where we compared the chemical urethane versus Coca-Cola for patients with new myeloma. And for the very first and perhaps the very last time in history, Coca-Cola made people live longer. And we learned the lesson not to do any harm to our patients by giving them toxic chemicals. In the early 1980s, we did the very first autologous transplant for myeloma. It continues to be in vogue, one of the most effective form of treatment, even 40 years later. In 2002, I was not even in med school, and we had 2 drugs for myeloma. Patient was succumbing to their disease within 2 years of diagnosis. And in 2025, when I am a myeloma doctor, we have 25 drugs in more than 50 combinations that will make you look at the NCCN guidelines like the Cheesecake Factory menu. There are too many options to pick from. So what is the real world evidence on the efficacy of CAR-T for myeloma? What are the differences between the real and the real world? Before I try to convince you that how CAR-T cell therapy has revolutionized the treatment outcomes for relapsed myeloma, I have to set the premise by explaining to you what triple-class refractory myeloma means, because this is going to be a consistent theme throughout my presentation. So if you have a patient who has been exposed to and become refractory to at least one proteasome inhibitor, at least one immunomodulatory agent like Revlimid, and at least one CD38 antibody like daratumumab, those patients are known as triple-class refractory myeloma. If you choose to give these patients traditional, regular, run-of-the-mill commercial chemotherapy, on average, 25% of them will have a response. On average, 5% or less will have a complete remission. Usually, the remission will last for about 6 months, and patients with triple-class refractory myeloma succumb to their cancer within 12 months. And this was the exact same population that we took with triple-class refractory myeloma, 6 prior lines of therapy, 1/3 of them having high-risk cytogenetics, extramedullary disease, high disease burden, less than 6 months to live, gave them single one-time infusion of a CAR T product by the name ide-cel, 80% of them had a response. 40% got complete remission, median progression-free survival of around 12 months, and median overall survival of more than 3 years when they actually less than 12 months to live to begin with. And that led to the FDA approval of the first CAR T-cell product from myeloma, ide-cel. It looked very good on a trial, so we tested the hypothesis in the real world. US Myeloma Immunotherapy Consortium is a national collaboration of 25 centers that look at CAR T-cell therapy in the real world. I had the privilege and honor of being a part of a steering committee, leading some of their studies, and the very first one we conducted was actually looking at the real-world efficacy and safety of CAR T in relapsed refractory myeloma. What we learned from this study was that 80% of the patients in the real world in our clinics who received this therapy would have been ineligible to be on the trial because of multiple reasons, being frailty, comorbidities, previous treatment exposures. Yet, their efficacy outcomes were exact mirror reflection of what you would have seen on the clinical trial. This was presented at ASCO meeting, later published in JCO. At ASH 2018, a group from China presented some data on a unique CAR T product, which when given to patients with relapsed myeloma, led to a response in every single one of them. All of them were MRD negative. The data at that meeting was looked at with a lot of skepticism because of the patients who were put on it, their follow-up, and very importantly, not having details on the CAR T product. At ASH 2021, same CAR T product given to patients in US was presented as part of the CAR T1 studies, with 100 patients with triple-class refractory myeloma, 6 prior lines of therapy, 1 in 3 having EMD, high-risk cytogenetics, high disease burden, receive a single one-time infusion of this CAR T known as cilta-cel, and 98% of them responded. 80% achieved MRD negative complete remission, and the median progression-free survival was beyond 3 years. I was at the meeting, and actually I saw physicians fall off their chairs looking at this data, because never before in human history, and this may be challenged later today, we have stumbled upon a therapy which is given to such heavily pre-treated relapsed refractory patients who may have less than 12 months to live. Every single one of them responds, and the response after a single one-time infusion can last beyond 3 years. That led to the FDA approval of cilta-cel autoleucel or cilta-cel for relapsed refractory myeloma. We tested its weight in the real world, and we found exact same thing. 80% would have been ineligible to receive it on a trial, 20% had out-of-spec product, yet your efficacy is very similar to what you have seen on the clinical trial. We live in a world of Kim Kardashians, Patrick Mahomes, Taylor Swift, so it's only fair that we draw comparison and contrast between ide-cel and cilta-cel. So as US Myeloma Immunotherapy Consortium took this on as well, knowing that it would never be a randomized controlled trial, more than 500 patients with very careful, statistically guided, matching adjusted analysis, looking at ide-cel versus cilta-cel. What we learned is that no matter how you slice the data, what kind of patients you look at, whether they have EMD, high-risk cytogenetics, high disease burden, cilta-cel almost always invariably outperforms ide-cel. The only caveat here being that patients who get cilta-cel may be at high risk of having neurological toxicities, but they do get better efficacy when given this product. And that is one of the reasons why I, when see patients in my clinic, would usually pick cilta-cel as a product of choice, with the caveat that if I have someone who is elderly and have some cognitive impairment, I may choose to give them ide-cel. So if someone asks me, how do you look at ide-cel versus cilta-cel? I will have a very simple answer and let the person interpret the answer. If ide-cel is Yahoo, cilta-cel is Google. You pick your browser here. CAR T has been moved in earlier lines of therapy. CAR T4, KarMMa-3 trials looked at CAR T in earlier lines of treatment. Patients were not as heavily pre-treated. 2 prior lines of therapy clearly showed us that it can be better than a standard of care chemotherapy. What is of more interest and value here is a subgroup analysis of this trial known as CAR T4, where we looked at patients with functionally high-risk myeloma. Functionally high-risk myeloma means a myeloma that progresses within 18 months of frontline induction therapy or 12 months of their transplant. And these patients tend to have significantly inferior outcomes. What we learned on this trial is that patients who have functionally high-risk myeloma, when they receive cilta-cel, tend to preserve the efficacy and have responses as deep and as durable as patients who would not have functionally high-risk myeloma. And that is one of the rationale that we at our side at MSK utilize when choosing patients for CAR-T in early lines. Not every first relapse in MSK is going to get cilta-cel. We will choose patients who have cytogenetically high-risk myeloma or who have functionally high-risk disease that is progressing early after transplant or frontline therapy. Daratumumab is being increasingly incorporated into frontline therapy as induction, as maintenance, but many patients who are exposed may not be refractory at the time of their first relapse. Dara-based therapies can be a good salvage option for these patients. So we actually investigated this question in our own cohort, on our own patients at MSK, looking at patients who are DARA exposed but not refractory, and found when you compare DARA naive, DARA non-refractory and refractory patients, there's no significant difference in outcomes with efficacy. Again, building a case that not every single patient needs to get to cilta-cel at their first relapse, especially when they are DARA non-refractory. CAR T-cell therapy is being increasingly moved to earlier lines of therapy. I would highlight CARTITUDE-6 trial here, which is actually pitching CAR-T versus transplant. While I think that CAR-T may be a better option for patients who have high-risk myeloma by cytogenetics and other characteristics, whether it's really going to challenge and dethrone transplant as a frontline therapy, I'm skeptical about it, because I think transplant has stood the test of the time and found to be very effective therapy over all these years. We do notice neurological toxicities I'm going to focus on later today as a highlight of my presentation. And if we start seeing more of these happen in the earlier lines, the question comes up, have we really put the cart in front of the horse? Just moving on to the unmet needs in CAR-T for myeloma. This is some of the work I have actually led with US Myeloma Immunotherapy Consortium, looking at what predicts failure of CAR-T, which means not having a response at all or progressing within 3 months of getting CAR-T. We looked at about 215 patients who received ide-cel for relapsed refractory myeloma. And what we determined in this particular study, which was later on published in Hematologica, was that patients who have one of the 4 risk factors are at high risk of early progression within 3 months of ide-cel. Patients who get BCMA-directed therapy, like bispecific, 6 months in the prior to CAR-T. Patients who have active EMD at the time of CAR-T, patients who have a lot of inflammation, immune dysfunction, represented by high ferritin that everyone gets checked at the time of CAR-T, and finally, patients who have high-risk cytogenetics. If you have all 4 of these risk factors, by calculations, you have an 85% chance of failing CAR-T with these particular risk factors. Are these modifiable? I don't believe so. I do think that you can avoid BCM exposure prior to CAR-T, but really EMD, extramedullary disease, and high-risk cytogenetics, that inherent to the disease biology of the patient. Hard to tease them out, hard to address them. I do think there is some potential for research here, and some of these trials are going on at sites like MSK, where patients who have these high-risk factors and a high risk of progression early after CAR-T, we're actually offering them consolidation bispecific antibodies for a time-limited duration to overcome some of these bad predictors of progression. We used the same model and applied it with our friends across the pond in Europe and came up with this model called MyKRIM model. It's available online. It's a tool calculator. You plug in the numbers and it will actually show you what is the chance of actually progressing early after CAR-T. Moving on to some of these predictors of early progression, extramedullary disease, in my opinion, is one of the biggest predictor of early progression or lack of response to CAR-T. The underlying rationale being that when you have active EMD, you have a lot of immune dysfunction, you have inhibited tumor microenvironment, you have exhausted T-cell phenotype, that you may see an initial response, but you typically progress within a few months' time, even after seeing a response. What we learned from this study that I led was that patients who have active EMD have inferior outcomes. Having said that, if you have a history of EMD, if you have paramedullary disease, or if you have no EMD at all, your outcomes are still as good as someone who never had any EMD. Another predictor of early progression is prior BCMA-directed therapy before CAR-T. And I do want to slice this data even further. This was an effort that we do through the consortium. And what we determined and learned from this particular study is that if you have a patient who is getting CAR T-cell therapy given, and you expose them to a BCMA-directed bispecific antibody within 6 months prior to CAR-T, You have them on treatment for more than 6 months, and your interval between the last treatment with your bispecific antibody and the CAR T infusion is less than 3 months, you are destined to fail that CAR T. What is the underlying rationale? MSK is actually investigating that. We do think that it's a tonic clonic stimulation of the T cells that leads to a more exhausted T cell phenotype that leads to an impotent CAR T cell. We do think that there is some degree of BCMA loss as well. And that's not just a structural loss, that's a functional or conformational loss where you still have the BCMA expressed on the surface of myeloma cells, but it has a conformational change where it does not bind to the CAR T. We are doing TCR sequencing. We are doing whole genome sequencing for these patients to determine whether they have a structural or conformational loss of BCMA. Moving on to some of the unique toxicities for myeloma. I'm not going to talk about CRS and ICANS. They're common, they are expected, they are manageable. We've learned so much from our lymphoma folks and applied all of those principles in myeloma and leukemia. But what I'm going to talk about today is some of the unique toxicities, including prolonged and persistent cytopenias. Cytopenias are very common after CAR T, no matter it's a heme malignancy or a solid tumor. Early on, what you see is cytopenia related to lymphodepleting chemotherapy. It'll get better by a month time. But there are patients, I would say nearly 30% of the patients would have persistent, prolonged, severe cytopenias that can actually last beyond 3 months. And you start looking into the risk factors associated with those cytopenias, you will see that patients who have CRS, cytokine storms, inflammatory cascades, and a significant disease burden, you end up seeing prolonged persistent cytopenias because of inhibition on the hematopoiesis for these patients. These cytopenias can be associated with the risk of transfusion, infections, and bleeding complications. And this was, again, a study that we published looking at these cytopenias and their outcomes. At my first faculty position at Medical University of South Carolina, I had 2 such patients who received ide-cel and had persistent prolonged cytopenias requiring transfusions twice daily, bacteremia, infections, bleeding. So I actually took the courage of giving them previously stored hematopoietic stem cells from a transplant back into to these patients. And I noticed that within 2 weeks' time, these patients were recovering from their cytopenias, had full engraftment, transfusion independence, and recovered their counts and other transfusional needs. I applied the same principle to 25 more patients, and we published for the very first time in US the experience of using hematopoietic stem cell boost for post-CAR T persistent cytopenias. And we learned that very reliably, these patients recover their counts within 2 weeks' time after getting the stem cell boost. With important caveat here that every single one of these patients had assessments done with labs, imaging, biopsy, to first of all rule out persistent disease. Secondly, rule out any MDS or other hematologic malignancy that may have developed. And finally, rule out any infections before you give them a stem cell boost without any conditioning chemotherapy like melphalan. This is a very important slide that I'm going to show you here, that if you are dwelling with cell therapy for solid or heme malignancies, you will see that in the coming months, one of the most significant area of focus when it comes to toxicity is late onset neurological toxicity, especially for myeloma, especially for this product known as cilta-cel. When the cilta-cel was first studied in China, we did see some of these late onset neurological toxicities. When it was studied in trials in US, we had gotten smarter. So we were debulking these patients, we were more aggressive about the monitoring, and we did not see as high an incidence of late onset toxicities. However, when we dished it out in the real world, we started noticing that there is a significant incidence of late onset neurological toxicities after CAR T. They can be divided in 3 big domains. The very first one being cranial nerve palsies. The cranial nerve palsies can be seen in 20% of all patients who get cilta-cel after CAR T. Most commonly is cranial nerve 7th, Bell's palsy, easy to treat with steroids. You can also see cranial nerve 5, cranial nerve 6, and also multiple different cranial nerves affected at the same time. You can give IVIG, you can give steroids. And we looked at this consortium-based study that actually was the very first study to look at late onset toxicity, and what we found it as motor and neurocognitive toxicities can also be seen in these patients, where you will see an entire spectrum of patients who have cognitive decline, patients who have personality changes, patients who have resting tremors, and patients who have gait abnormalities. In other words, they will resemble a patient that looks like a Parkinson's patient. I have 5 such patients in my practice at Sloan right now who have developed one or form or the other of a late onset neurological toxicity that resembles Parkinsonianism. We also seen Guillain-Barré syndrome in these patients happen. And the tricky part here is that many of these patients, one of the factors that we have learned is that many of these patients are not as heavily pre-treated. They have fewer lines of therapy, have low disease burden in the bone marrow. Hence, they are more robust T cell expansion, persistent, and that perhaps explain why we are noticing these late onset neurotoxicities that can severely impact quality of life. We are actually doing a study at MSK where any patient who receives myeloma CAR-T and have their ALC, absolute lymphocyte count, go above 5,000 between week 2 to week 4 post-CAR-T, we actually measure their cytokines. We actually measure the CAR-T levels through a PCR, and we do a T-cell phenotyping on all of their T-cell repertoire. We start them on dexamethasone 10 milligram BID for about 5 days and see how that actually helps with some of the ALC coming down. Reason being, every single one of the patient at our site who has had a late onset neurological toxicity has had an ALC above 5,000 in that time interval. It's 100% sensitivity. We are about to present this or show this data with the T-cell expansion, persistent, and CAR-T at the IMS meeting. CAR-T-related HLH, we have a new name for it, IEC-HLH, immune effector cell-associated HLH. This is one of my patients who received ide-cel for relapsed refractory myeloma, heavy disease burden, had a fever within 6 hours of ide-cel that responded to toci. And 5 days later, you can see here that the patient starts having elevated liver enzymes, fevers that are not responding to toci, and then their ferritin is more than 100,000. By day 5, we actually initiated high-dose steroids along with anakinra, and within 5 days' time, we see an improvement in the cytokine storm. And that is what you typically end up seeing in IEC-HLH. I've seen this happen with lymphoma patients. Important thing to remember here would be that they don't need to fulfill the entire criteria for HLH that historically exist for patients who have lymphomas and infections or idiopathic primary HLH. You don't need to have NK cell activity, fibrinogen, other things. All you need is fever, some end organ damage. And one very important predictor that we have learned from our own site and our own data is that if your lactate doubles in 12-hour time, this patient is highly likely to develop ICHLH. So what we do at Sloan is that we give steroids and anakinra right at the very onset. If we don't see a response, we will pull out a very expensive but an extremely effective drug by emapalumab, which is essentially an interferon gamma antagonist. We have shown some data as a tandem meeting. In my own practice, I have seen lymphoma patients getting lysocell, having rip-roaring ICHLH, and within 24 hours of emapalumab, I've seen them come off ventilator, off 3 pressors, and have the neurological toxicity also improve. So this is something to keep in mind if you're giving CAR-T to patients, especially with rapid expansion. Again, the concept is not old, and this takes me back to my days in Louisville when I was a fellow. I did a rotation at Moffitt and worked with Marco Davila in his lab, and they had 2 patients who had CAR-T-related HLH in 2018. We published these cases and showed that late onset CRS that is not responding to toci has a very different inflammatory cytokine cascade that you may want to address with agents other than tocilizumab. Moving on to how we choose and sequence CAR-T and bispecifics. But before I do that, I do want to say that pentaclast refractory myeloma that has seen and refractory to 2 PIs, 2 IMiDs, and a CD38 antibody has very poor outcomes. Anything other than a cellular therapy, other than an ADC, a bispecific, or CAR-T that you choose, will not be successful in these patients. This is one of the studies that we published showing the outcomes in these patients. I actually did a survey, led the survey using that platform of ASTCT committee, where we sent the survey to 1,000 physicians all across the world, asking them their treatment patterns for post-CAR-T relapse. And what I learned is that for patients who are actually relapsing within 3 months after CAR-T, vast majority we choose bispecific talquetamab. For patients who relapse beyond 3 months, teclistamab, alemtuzumab were the most preferred choices. So what's the evidence behind it? And here I'm going to walk you through some scenarios as well, that can you use a BCMA or a 5D bispecific antibody post-CAR-T relapse. This is a study we led with a consortium based in Germany, where we learned that anyone who progresses after CAR-T, whether they progress in 3 weeks, in 3 months, or 3 years, your outcomes are the best if you choose a bispecific antibody for a post-CAR-T relapse. For relapses that happen early, talquetamab leads to best outcomes. And for relapses that happen later, teclistamab and talquetamab are equally good options. Options including debulking chemotherapy, CD38 antibodies, IMiDs, they're not as good as compared to the bispecific antibodies for these relapses. Second question that comes up is that can you use a BCMA antibody prior to a BCMA bispecific antibody prior to a BCMA CAR T? I would say the answer is no. And this is the study that clearly established it, that if you have a patient get a BCMA bispecific like teclistamab or lanatamab 6 months prior to IDA or cilta-cel, your outcomes are going to be significantly inferior. So I always caution my referring providers that not to use bispecific, especially for a long period of time prior to the plan to go through CAR T. The last question that comes up is that can we use GPRC5D CAR T instead of BCMA CAR? Answer is yes. This is some data that was published, that's about to be published, that looked at using talquetamab as a bridge prior to CAR T. And this did deepen responses, did not affect efficacy of CAR T, and we are also able to manufacture healthy CAR T. Now the question comes up, the last one is, can you use a GPRC5D CAR T right off the heels of a BCMA bispecific relapse? For instance, you are on TEC or ALDA and you progress, can you just salvage those patients with a 5D CAR T like talquetamab? And this is the MSKCC data. We looked at 50 patients with talquetamab. 70% of them were BCMA refractory. 50% had received as last line of therapy. You can see that median PFS is 6 months, overall survival 12 months. And this is the data I wanted to show you, that when you use sequential bispecific therapy, someone is progressing on one bite and you just bring it in a second bite to salvage them at their relapse, you may see an initial response, but it's not going to last beyond 2 months. And I think that again speaks to the fact that a lot of these T cells are exhausted, they're clinically stimulated, and do not lead to durable remissions. Highlighting some of the future directions for myeloma, I will quickly walk you through some of the important developments that are happening in myeloma. Arlo-cel is a CAR T that targets GPRC5D. GPRC5D, interestingly, is a receptor that I would not have hesitation to say was invented or discovered at MSK. One of the lab scientists found it in the skin, keratinized tissue, as well as inferior olivary nucleus. It was later developed for a bispecific and now being tested for a CAR T for myeloma. It's very deep and durable responses. It does not cause the same skin GI toxicities that you see with talquetamab, but there is a toxicity signal with cerebellar toxicity seen where patients are becoming dizzy, lightheaded, cerebellar ataxia that does not get better. So I think this is a major toxicity to look forward to before we bring this into practice. The second CAR T that I will talk about here is anito-cel. Anito-cel is a particular CAR T, BCMA directing CAR T product that has a special sauce in its antigen binding site. We call it a D domain. It's small, it's compact, it has a very high CAR vector expression, and has a very easy or high off rate, which means it binds and unbinds very quickly, which means that it can lead to a very deep and durable remission and not lead to as significant a toxicity. And that is what was seen in this particular pivotal phase 1 study, where 100 patients, when they received it, had a very deep durable response lasting beyond 3 years, as good as cilta-cel, but not having any patient develop cranial nerve toxicities, motor neuron toxicities, or Guillain-Barré syndrome. So I think this is a CAR T that may give cilta-cel a run for its money. And finally, I'm going to talk about some of our own internal studies, data using AI that we have looked at, predicting lack of response to CAR T and bispecific in real time, which means you're about to start someone or a CAR T or a bispecific. Can you reliably predict that this is a patient who is not likely to have a response, should perhaps consider another option, makes it a consolidation as a trial on a different treatment? So at MSK, utilizing our immune discovery department, we were able to look at 200 patients with myeloma who received CAR T cell therapy. 80 out of 200 patients actually had a 20 panel of labs and cytokines available. We were able to cluster them as inflammatory or non-inflammatory phenotypes. And what we learned is that the patients who were inflamed had significantly inferior progression-free and overall survival, regardless of what product you give, how much EMD, hydrocytogenetics, and disease burden they may have. We used AI modeling and machine learning, where we filled in the gaps in the labs because we don't have 20 cytokine panel for every one of the 200 patients. So we filled out those gaps using AI modeling and learning, and actually came up with a set of 7 different labs at a time of lymphodepletion. and again stratified these patients as inflamed and non-inflamed, and found that the outcomes are still very clearly distinct, where inflamed patient has significantly inferior outcomes. These are the labs that every single patient with CAR T, whether it's solid tumor or heme malignancy, would be getting at a time of lymphodepletion. And we showed with reliability that if you have these models, if it has these labs, and you plug them in our model, which will be available as a tool, you can determine who is inflamed, who is not, and is at high risk of having inferior outcomes, regardless of all other major predictors of progression. This is work. This project is in the works. It's been presented at EBMT. We are planning to actually submit this to IMS as well and apply for this tool and calculator. We are doing a lot of correlative science as well, looking at TCR for the CAR T cell, for its persistence, for its expansion. We are looking at some of the whole genome sequencing as well for the resistant mechanisms. But it's a very interesting concept that is in the development right now, having a biomodel called Inflamix to determine inferior outcomes. Some other things that we have done at our side is that we have given talquetamab to patients and learned that once you have given talquetamab and no fevers at the third dose, you don't need to do the fourth dose in patients, so you can be discharged easily. Similarly, we learned that patients who have a prolonged delays in bispecific antibodies, let's say a hiatus of 4 to 8 weeks, you can still give them bispecific antibodies in the outpatient without any need for step-up dosing. We have also learned pseudotumor flare with bispecific antibodies. This is one of my patients who got talquetamab given, had orbital myeloma, which swelled up within a week, responded very well to steroids without requiring radiation, and continued therapy to have ongoing response. So pseudotumor progression can be seen with bispecific antibodies for these patients. Finally, some future directions. I think when it comes to bispecific antibodies, it's very important to sequence them in a right way, and more importantly, administer them the right way, the right frequency, and for these patients. Similarly, sequential therapy with bispecific antibodies, what we are doing at our side is that we are doing comprehensive T-cell phenotyping. We do high spectral flow analysis for these patients. We are doing whole genome sequencing to look at the surface protein expression of BCMA and 5D, because immune histochemical analysis and traditional flow cytometry, they're not reliable. They're not reliable, they're not validated. Hence, whole genome sequences not only looks for the structural loss of the protein, but in fact also looks for the kind of functional loss or the conformational change of this protein on the surface of the cells. And finally, trying to overcome some of the exhausted phenotype with the T cells, we are having trials that are potentiating effect of T cells by combining bispecific antibodies together, 5D and BCMA, combining BCMA antibodies with immunomodulatory agents, CELMoDs, and finally combining them with daratumumab-based treatments as well. Again, using Inflamix, which is one of the predictor models, using some of the traditional studies we have done at predictors of progression, we can identify patients who may be at high risk of early progression or relapse, and these are the patients that we are targeting with these combination therapies. This is a group of MSK myeloma team. We have actually 2 or 3 more members added to this team. I don't have their photos up yet, but we are 15 myeloma doctors. We have more than 10 doctors in addition who do transplant and cell therapy. So big group of 25 physicians who work all over New York City and really focused on cell therapy and innovation. And with this, I come to the end of my presentation. I'm happy to take any questions if there is time. Yeah, so we are hoping to have it available online in next 6 months. Right now, what we are doing is that we are validating the model in about 1,000 patients through the CIBMTR platform. Because we already done internal validations with our own MSK CAR-T and bispecifics. We've done with a German site as well. Once it's validated a larger data set, I think we'll have it available for public use. You can just click on it and plug in the numbers, and it will tell you it's inflamed or non-inflamed, and then it also shows you the outcomes of the progression-free, survival, relapse, and things as such. It can be done at a time of lymphodepletion and not just necessarily infusion. Yeah, so CARTITUDE-6 is a trial. It's a phase 3 randomized controlled trial that is looking at CAR T versus transplant as a frontline therapy. Patients do end up getting induction, then they do either CAR T or they do transplant, and they do 2 years of maintenance, and they can stop all treatment after 2 years if they're MRD negative. I have been enrolling patients on that particular trial. I have a lot of experience with that trial and patients going on CAR T. I think the way the trial is designed, it's destined to enroll patients who have biologically standard or good kind of myeloma. It will be very hard for CAR T to beat transplant for a patient that happens to be a standard, regular, run-of-the-mill myeloma, because median PFS with 4-drug induction therapy, transplant, and maintenance is actually of the order of 10 plus years PFS. Try beating that with CAR T is going to be hard. Having said that, for high-risk myeloma, I do think there is a role of CAR T. It may actually overcome some of the intrinsic biological resistance that exists to high-dose chemotherapy. But from my own experience, I have a lot of patients coming on this trial. I think we are, in one way or the other, excluding those patients going on to the trial with some of the requirements. So I think transplant is here to stay, especially for standard risk myeloma. There is a role of CAR T for high risk. Frontline. Thank you. Yeah, all of those patients have had previously collected, stored hematopoietic stem cells. Yeah, every single one of them. We actually have another trial open, an MSK, where we do make an attempt to collect those stem cells if we can, and then do a second transplant for those patients. So if there is, for instance, a patient who's relapsing, relapsed refractory myeloma, what we would do is that we would collect their stem cells, give them high-dose melphalan, give them the stem cells, and within a month of recovery of counts from the stem cells, we actually use those new T cells after immune reconstitution to make them into CAR T and then take them to transplant. So this is a very cool concept. It's called Big Bets. It's known in the domain as a trial, but it's looking at that particular question.
Curious to know, like, the inflammatory versus non-inflammatory patients population. Can you comment on it? Because inflammation is a general phenomenon, right? Like, it is a pro-inflammatory or is it an anti-inflammatory, number one. Number two, whether they do receive prior treatment or they are naive patients.
Sorry, say the last part.
Whether these patients are like naive patient, they were not treated previously, or they treated already with some others.
Yeah, so when we looked at the inflamed versus non-inflamed phenotypes, these were all previously treated relapsed refractory myeloma patients. Their inflammation was a measure of immune dysfunction, a reflection of disease biology, extramedullary disease, high disease burden. But we actually controlled for all of these factors in our multivariable analyses, and you can do that. And yet we were finding that even in patients who did not have EMD, high disease burden, and they were inflamed because of one reason or the other, they were having inferior outcomes. So inflammation is a reflection of disease biology, a marker of immune dysfunction, and very clearly associated with non-persistent CAR T cells. And I eventually will show this data as well, that these CAR T cells, they expand, but they don't persist very long. And that is perhaps one of the reasons why we are seeing inferior outcomes in these patients. The model in itself has 20 different labs. It has 12 cytokines that we check, and in addition to some of the labs. But a simplified model that is derived from the initial model that we used has only 6 or 7 labs that we use.
Thank you.